Hello everyone, good afternoon. We are right on time. So joining us here today is none other than Dr. Natasha Noor, fertility specialist at KL Fertility Center. And I'm your host today, Nikyu, Center Manager of KL Fertility Center. So I'm glad that we are right on time today. And as what we have teased you guys a few days ago, today we're going to talk about A to Z Fertility Bootcamp, and it's going to be presented by none other than Dr. Natasha Noor. Yeah. So without further ado, I would like to introduce Dr. Natasha to the screen. Hello, Dr. Natasha. Say hello.
Hello, hi.
Okay, so we have people joining us already, and that's great. So stay tuned until I think the whole webinar will take about an hour
1
because
hour.
it's called 60 Minutes with Dr. Natasha Noor.
Yeah.
So I shall pass the mic to Dr. Natasha. And if you would like to send us an inquiry or a question, please feel free to put down in our comments below. And let us know if you can hear us as well, because this is our second time on Facebook Live, and we would like to make sure that everything is going on fine. So, so come on, let's wrap up. Dr. Natasha, come on, let's go.
Yeah, let's go. Right. Good to go?
Yeah.
All right. Okay. Assalamualaikum and a very good afternoon. For all those of you are here already on a Saturday afternoon, ready to learn and have an A to Z Fertility Bootcamp. Right? So let's go. So are you ready for bootcamp, everybody? Let's hear a shout. Yes, are you ready again for bootcamp? I hope you are. So we go, yes, ma'am. Yes, ma'am. We are ready to go. Now, why the idea of a fertility bootcamp is basically like for a bootcamp, we want to give you the basic tools for you to prepare for your journey, because fertility journey is basically, for some people, it'd be a really short 100, 200 marathon camp, but for quite a number of you, you're going to go through the fertility journey, and it may take months, it may take years, right? And you feel that you will be running and you'll be on this journey for an eternity. It feels like an eternity with no ending. But I reassure you, with the proper preparation, the basic tools that hopefully this afternoon will give you, that you'll be able to maneuver your way through this fertility journey faster. Right? So it is basically when you want to prepare for a journey, you want to prepare for something very important, it's best to prepare as a whole. So emotionally, physically, especially psychologically, and also actually for treatment, it will be also involving financially. Right? I hope to prepare you with the basic tool and also enough important information for you, especially in pertaining to fertility, so that knowledge actually goes a long way to prepare you mentally for what is ahead. Right? So you'll be making informed decision, and you'll be prepared for whatever it is along your way. So next, we are basically going to cover a few things, right? Our training modules, right? It's a fertility bootcamp. Our training modules is basically first understanding your basic fertility. How are you going to look after your fertility? And what are your fertility options? What is IVF fertility treatment, and how to optimize your IVF treatment? Since I'm not sure where you are in your fertility journey, I intend to cover as much as possible of the couples who are in their fertility journey. So it's either you're a newbie or you're more a seasoned traveler in your journey. For those who are just about to embark on the journey, they need to understand the basics. So for those of you who are already have much more information, perhaps there will be a revision for you. Right, a revision, and maybe who knows, you'll be picking up a few more new information that will be useful for you to help you along your journey. Okay, so we basically know, in general, 1 in 6 couples will face issue with fertility. It's not they are infertile, they are basically subfertile. They have a little bit of issue, and majority of you will be able to conceive, and depends on how your background, the age, and what are the fertility issues. Some of you will be able to conceive spontaneously, and some others will probably need a little bit of help in terms of fertility treatments such as IUI or IVF. Okay, so we're good, right? Next one is basically a lot of people will be wondering, how does fertility works? How do I conceive? So back to basic science class. Basically, this is a female reproductive system. We have the vagina here. So when we have sex, the sperm will fall up here to go up into the uterus and up into the tube. So before we know all those procedures, let's know the basic of the anatomical female reproductive system. So the vagina, cervix, this is the uterus or the womb where the baby implants and grows. It's a triangle in shape, and we have two fallopian tubes, right and left, and we have two ovaries, right and left. Now, in order to conceive, you need four things, right? You need a good sperm, right, and a normal uterus. One of the fallopian tubes must not be blocked, and you are ovulating. So when you have sex, basically, the sperm will fall here in the vagina. It is basically a swimmer, as we all know. It goes up into the uterus and up into one of the fallopian tubes. Now, if it's the right timing and it's the female partner's fertile period where she is ovulating or have ovulated, so it's either going to come from the right side or the left side. Normally, we only ovulate one egg at a time. So it depends. Let's say it comes out for this one is on the right side, so the sperm comes up here and the eggs will actually be floating somewhere in the tubes. The sperm comes here, fertilize the egg, and then develops an embryo, which then will roll down and implants into the lining of the uterus and grows into the baby. Now, a few things that when we do, then there's a few parts that may causes an issue. Let's go next, and we'll go through that in detail perhaps later on in the slides. So a lot of couples, when they are trying for a baby, they'll be wondering, do I actually have a fertility problem? So how do I know whether I may have a fertility problem? So in general, subfertility is basically the inability of a couple to conceive within a year with regular sexual intercourse and without usage of contraception. So what do we mean by regular sexual intercourse? Means the couple would have had done sexual intercourse at least 2 to 3 times a week, right? Without the usage of any contraception. So when statistics, we have a look at the statistics, about 88% of normal couples without a major issue in subfertility will have conceived in a year. And another 92% of couples will have conceived within 2 years. So if you're wondering whether you may or not have a fertility problem, you have regular sex and you're still unable to conceive within a year, then you may have a fertility issue. So it's best for you to go and seek help. So my advice is, basically, if you're less than 35 years old, you have regular sexual intercourse, there are no issues in having sex, you don't have contraception, you don't have irregular period or known gynecological problems such as polycystic ovarian syndrome or endometriosis, if within a year you have not conceived, then it's wise to actually seek medical treatment, perhaps see your gynecologist or perhaps see a fertility doctor just to have a checkup. Right? If you are perhaps younger, you may want to wait for about up to 2 years. But those who are more than 35 years old, have irregular cycles, perhaps it's best to see a bit earlier, perhaps within 6 months. And if you are a bit much older, let's say you get married a bit later, there is not a problem for you to come and see the doctor, maybe perhaps getting married even maybe 2 to 3 months before. We'll have a quick checkup, we'll put you on folic acid, and hopefully you can be able to conceive within months of you getting pregnant, right? So there is no right or wrong, but in general consensus is 1 year. But if you're younger, you're ready to go, you don't need to wait 1 year. Go ahead, have that checkup, even when you're trying for at least only 6 months. Okay? So not an issue. Now, what are your chances of getting pregnant? As you can see, this is basically the female age because the age of the female partner plays an important role in determining the chances of that couple getting pregnant. Because the younger the woman are, then her eggs most likely will have a lot of eggs and more better quality and less abnormality. So that will be associated, as we know, with better chances of getting pregnant every month they are trying. So if you're in the 20s, the female partner, you have a chance of getting pregnant at least about 20 to 25%. And if you can see, this drops further with age. Right? This is something that we know. So if you feel that, when you are seeing the doctor, we actually will ask one of the most important question is the female partner's age because it gives us a prognosis in how fast you are be able to get pregnant, whether you will be able to get pregnant, conceive not spontaneously, or you may need to be getting pregnant soon because the age is catching up, right? So why is this so? So this is basically a graph showing the age of the female partner from 0 up to 51, where majority of women in the Asian culture will get menopause. What does menopause means? It's basically stopping of period because the woman basically has run out of eggs. Just because you have a regular cycle, maybe in your 40s, in your 45s, doesn't mean to say that you are fertile, right? It may be that you're seeing your last few eggs and that eggs are good quality. So for us, you probably see if you're ready, we can see from this graph even, right? The number of follicles versus the age of the women. So optimal fertility for a female actually runs from 18 up to 31, right? Even the late 20s, a female would probably see a little bit of drop in their fertility in view of the reduction in the number of follicles. Not only is reduced in the number of eggs, there is also a decrease in the quality of the eggs. So you can see there's a drop, slight gradual drop, and you can see a very fast, steep decline in the fertility because of the follicle number as we hit in our 40s. And by 45, you would have irregular cycles, means you're not ovulating regularly, possibly due to egg numbers gone down very much rapidly, or the quality of the eggs is gone down. So we would then, if you're in your mid-30s, we would probably move you along quickly and, advise the couple to perhaps see treatment which may get them pregnant faster. Okay, so this is just again another summary of the female age versus the fertility status, right? We are all born millionaires. We all have more than 1 million of eggs by puberty. You use it or you don't use it, the eggs will die and disappear. So you will have 300,000 eggs remaining, and within the next few years of your reproductive years, you probably ovulate and release roughly about 300 eggs, and with that, whether you use it or not to make babies or not, it will be gone. So also we need to understand that about half of those embryos, which means eggs which have been fertilized by sperm, will have undergone spontaneous miscarriage, which increases with number because of the egg quality. Nature just spontaneously do not accept the eggs for a good reason, and you will have a miscarriage, right? Because also, if you can see, the chromosomally deformed embryo increases. If you were to compare a woman age 20 compared to a woman age 40, the risk of embryo abnormalities is 1 in 526 at the age of 20 compared to an age 40, 1 in 66. And by the time you hit nearly 50s, it'll be 1 in 8. So an increase in the number of miscarriages. Okay. Now, obviously, we have always tried to beat the age. You probably say, look, we are in the new era. There's always new technology, new medical advance, but unfortunately, we are still struggling with beating the biological clock. So we have heard about egg freezing, where we freeze the egg in time, hopefully to use it in future when the women are ready, perhaps after she finishes her education, her career. But we have known that this is possibly not your insurance, and it may still that you still need to hurry up and get pregnant quicker. The younger you are, the faster you get pregnant, and the better pregnancy rate it is, even though with a fertility treatment. Okay. Now, not any eggs we are concerned. Over the years, over the past decade, we have known not only in America, the sperm has been declining in not only the number of eggs, the number of sperm, but also the quality. So if you can see when you do a sperm analysis, a sperm test, it's been changed from when I was a medical student up to now when I'm practicing. The numbers are much reduced. So when you do a sperm test, make sure it's the latest criteria according to World Health Organization to compare whether yours is all right or not all right. Okay. Now, again, important things to know in general what causes subfertility. So we can roughly say now actually male causes are also on the rise causing subfertility in a couple. You can see from the graph about a third, 30% is caused by female causes, about a third by male causes, 25% is unexplained, 10% is both male and female, and another 5% is basically unexplained. Now, when you do fertility testing, which I shall go through later, you will realize that getting pregnant is really a complex issue, a complex process. You won't be able to identify each step, and to be honest, we are all a miracle. Okay, there's lots of steps that you have to undergo to make sure that you are born, you are conceived, you are born, and you made it this far. Okay, so you will understand that when we do a basic fertility testing, some couples will end up with a diagnosis of unexplained subfertility. Doesn't mean they have no issues, it's just that we do not know what are causing the infertility or subfertility. That doesn't mean we do not need to treat them depending on their age and their background, how long have they been trying. They should still move along and do some fertility treatment. So again, this is the female reproductive system. From the female side, we basically can have a few causes. It can start off with the ovaries, the tubes, or the uterus, or the implantation, and also maybe perhaps some infection right at the bottom here. So what we can start off with in the ovaries. What's the problem with the ovaries? Maybe ovulation issues. So a common one you can hear or know about is polycystic ovarian syndrome, or patient usually call it as Pcos, right? Pcos basically is a hormonal imbalance where the eggs does not mature. If it does not mature, then it does not ovulate, and that in turn leads to irregular periods. So that also, if you're not ovulating regularly, then that will reduce your fertility, your chances of getting pregnant each month. Now, polycystic ovarian syndrome, and at the tubes, you can have infections, you can have endometriosis, a disease which is common in subfertile women where it blocks and it causes the tubes to be swollen. And when that happens, then the eggs and the sperm could not meet and you can't have a pregnancy. So our first IVF baby anyway was caused by blocked tubes. Now, the second one, you could have some uterine abnormalities. There's some abnormal shapes in the uterus. Polyps is basically an outgrowth in the lining of the uterus. It rarely causes, a major issue. We can detect it during our investigations. Fibroid is basically a muscle overgrowth of the uterus, and it may cause some issues in terms of implantation. Another common cause of subfertility is endometriosis. Endometriosis is basically a condition whether you are genetically inherited or due to environment. It causes the lining, which is lined in the uterus, to be outside of the uterus within the pelvic cavity. And when this lining is outside, it causes inflammation within the pelvic cavity, inflammation, scarring, and also cysts within the ovaries. So all of those would then lead to subfertility in the female partner and difficulty in conceiving for the couple. Okay, this is basically we are moving for the next step, right? So for the questions, I will go through with you later on. I understand that there's already a few questions. Now, our top question would definitely be COVID, right? COVID vaccination. So let me go through step by step, and I can reassure you we can go through all those questions after the slides, right? Okay, so next, but go ahead, post it up because you may forget about it, and we'll go through it after the presentation. Now, the next step, as I promised, we would want to know how to make sure that you maintained your fertility, right? In order to know what are the causes of fertility, we need to maintain as well, right? For without a doubt, you cannot ignore your diet, right? Your diet is really important. You need to provide your body with good, nutritious, healthy, balanced diet in order for you to develop good egg, good sperm, right? So this is nothing, surprising. You're going to have to eat lots of vegetables. This is your plate, basically. So it's a plate, you take lots of vegetable. Half of it will be, 3/4 of it should be vegetables, right? And then you have some fruits, right? And a little bit of protein, and whole meat is good, but you would definitely reduce the intake of fatty, fried, fast food, which is really not good for your health, right? It causes lots of toxic buildup, and it causes lots of unwanted weight gain, unhealthy, and that would develop then soon causes you to have hormonal imbalance, poor egg, less number of egg, which then will reduce subsequently your fertility status, right? Again, an important thing, which is also if you do not eat healthily, you're eating excessively, you might have also a problem with your weight, either too excessive, overweight, obese, or you're underweight. So either way, for both the male and female partner, if you're trying to conceive, try as best to maintain a healthy diet and make sure you exercise to make sure that you are having the ideal weight, right? Ideal weight is important. So according to your height, you need to be able to know your BMI. Okay. Now, a lot of people are talking about stress as the cause of subfertility. Trust me, everybody has stress. Nobody leads a stress-free life. It's just how you deal with your stress. Okay, it may be excessive stress can cause subfertility. Excessive. So what we're gonna do, since we're not being able to lead a stress-free life, we're gonna be able to need to be able to handle the stress, identify the stress, and see what you can eliminate it or handle it well. Okay, some, no doubt, some patients are predisposed to have a personality which are more anxious. So how do they handle the stress, right? They might be maybe taking breaks, right? You need to sleep early, so that you have good rest. Make sure that you exercise. If you're exercising, then for some people yoga is good, especially for fertility, because it involves lots of stretching, lots of deep breathing exercise, which is good. And it's important to remain calm, because with the fertility journey, it's always you'll have little bumps along the way. You shouldn't worry excessive about it. Move along. Everybody will have those bumps, but it's not going to be a big major blockage in order for you to continue your fertility journey. So this, you must be aware that we will all have maybe some issues, but it will be able to overcome in majority of the cases. We probably need to see our options and see which is the best path for you to move along in your fertility journey. So at the end of the day, perhaps then hopefully majority or all of you will be able to achieve the goal of building your own family, i.e. getting pregnant. Now, one of the things that I find that, we are, not everybody overthink, right? Certain things, right? We'll think about the worst of things. We haven't even done it. We probably did before even done anything, right? You're thinking, okay, let's go and see the doctor because I think we're having maybe some fertility issue, maybe. And you think about all of the things that may go wrong, all of the blood tests that may show some abnormalities, and you're basically scared out of your mind, even to even see the doctor even the first time. So to me, just relax, okay? It's not as bad as you think. If you feel that you're thinking too much, you're just gonna have to control and train your thoughts to be more positive. Especially if you find yourself or your partner, you're going to have to be able to control and try to be as positive as possible. And sometimes you're just going to have to shut down and say, enough, we'll deal with it when it comes along. When we get to that bridge, we'll go to that bridge and we'll have a discussion. After all, majority of the tests, it will be normal, right? Okay, so we do have a basic fertility testing at KL Fertility Center, which aims to cover the common fertility testing so that by the end of the investigation, you roughly have an idea where you stand in terms of your fertility status. Do you have a problem or you do not have a problem? Yes, you may have a problem, and what we are able to help you with. So our fertility assessment package is 799. It basically includes consultation, scans, pap smears, some blood tests, and semen analysis. Of course, you may know that this does not fit everybody. It's in general, so you may need some other testing which is not part of the package. So see the doctor. We'll have a look and see whether you need extra tests or this package is enough to basically tell us what's possibly wrong or maybe not wrong. That is just a bit of delay. All right. So, biological clock, right? You always hear about this tick tock clocking. Is it real or is it just something to scare you off and make sure that you get pregnant, make sure you get married? But unfortunately, it is because for female we have eggs which dies and reduce in number, and we need to be able to conceive within that period of time. Unfortunately, we've been designed that way. So how do we check where we are on our biological clock? There are a few simple ways. One of it is having a scan, a vagina scan, basically to see your ovaries, right? This is one of the ovaries, and if you can see, there's an outline of this round structure which we call follicles, and within these follicles are potential immature eggs which we can't see because it's microscopic, but by counting the number of the eggs, it gives us an idea of your ovarian reserve. It does not tell you the quality, it tells you the quantity. So, and it's just a snapshot of that age. It may not be there for the next 1 year or 2 years, something might happen, but perhaps for the next 3 6 months, maybe maximum 1 year, it's roughly that's your ovarian reserve. Okay, so the test that we do is the ultrasound test to count this number of follicles. We call this as antral follicle count, AFC. Now, Mona Lisa, right? Went to Paris with a colleague of us, went to Louvre, and we were just racing into the Louvre Museum to see Mona Lisa. And when we get there, it was actually quite anticlimax. We were going like, okay, Mona Lisa. Right, because we can't appreciate. I suppose if we were a painter, an artist, you would appreciate more, right? In terms of the selection of the coloring, the brush strokes, you probably appreciate better. So this is basically to point out why some patients, I would say, they would say, okay, doctor, I've done an ultrasound. Here it is, and I don't need to do a scan. Why would you want to do another scan? I mean, it's different because it's the same thing when you look at the painting of the Mona Lisa, right? When I scanned, I perhaps see a different things and the angle is different, right? At least Mona Lisa, you have a snapshot, but when you do ultrasound, it's moving, right? So you need to be able to see certain things and see in detail. So just means that when you see, just because you look, you does not mean you see. So you see different things. But for an example, an abdominal scan, I always do a transvaginal because it's clearer. This is basically an abdominal scan where we can see the bladder, the vagina, and the uterus. But when I do a transvagina scan, this is the feature. If you can see, it's so much clearer. You can see the endometrial lining, which is important for us to detect any polyps or any other obstruction in the endometrium. And the most important is actually the follicles. No matter how thin you are, it's almost very difficult to see through the vagina, through the abdomen, the follicles. That's important for us to do an antral follicle count. So, whenever they come, yep, do a fertility assessment package. I say, please, I need to scan. We can talk till the cow comes home. You can tell me all your results, all your tests. I will definitely need to do a minimum ultrasound scan. All right. Okay. So that's basically for our fertility testing. In detail, what I would probably summarize for fertility testing, there'll be for male and female. Male is very easy, just do a sperm test. If there's an issue with the sperm test, then we have a bit more detail, right? Especially if there is no sperm in the semen that has been sent by the partner, that's called a zoospermia. Then the husband or that sort of partner will be undergoing a series of other testing to determine what's next, right? For the female, as you can see, we can see from the reproductive organ that there's a few things that you need to check, right? You need to check the ovaries, you need to check the tubes, then you need to check the uterus as well, and also hormones. So for the females, you usually consist of having a blood test, a scan, and also some an X-ray. All right, the X-ray is basically to check the tubes whether it's patent or not. From the ultrasound, it's not best to see the tubes. You can see, you're not meant to see the tubes with the ultrasound testing. So the doctor may advise you to do an additional test called HST, which is an X-ray, or depending on the ultrasound, you may need to do a more invasive testing, such as a mini operation, especially if you have a cyst or the tubes looks dilated. Then you would have come into an agreement, right? All tests done, fertility testing, do we or do we not have a problem? Then we sort of decide, should we have a plan A? Should we have a plan B? It's not the same way, even though it's similar problems for a couple, that couple may not choose the same decision. So that's where the discussion will come along with your doctor or your fertility doctor. What's your plan A and what's your plan B? I'd like to have plan A, plan B. It gives us sort of like an idea where we're heading and sort of a timeline, right? Because we do need to work against a timeline. The biological clock. Don't say, okay, in a few more months. I'd like to be a bit more specific. What, 6 months? 2 to 3 months time? 1 time? 2 time? It's always flexible, but have a plan. It's good to have it, right? Now, this is the fertility ladder, all right, treatment. So depending on what's the problem, then you'll be able to know what sort of treatment will be suitable. For every couple, you will have a lifestyle modification. You'll be evaluated in terms of your weight, whether you smoke, your alcohol, your diet, your exercise regime, whether it's adequate or you need to be increased in those, right? So whether it needs to be changed. Some people, you just need lifestyle modification and there you go, you're pregnant. Ovulation tracking is an extra. To me, if you're trying to get pregnant, best policy, 2 to 3 times of sexual intercourse. You're bound to have make sure that you are already doing during the fertile time. So instead of being obsessive about ovulation tracking, yes, you can do best policy 2 to 3 times a week of sexual intercourse. So it's a regular sexual intercourse. Now the next step is basically ovulation induction. If you heard about Clomid, you basically will have taken the tablets, and usually it's been given on the second day or the third day of the period, right? And then it'll be taken for about roughly about 5 days, and then the follicles will be monitored. About 8 to 12% of couples will get pregnant, so that's a good step. It's a simple step, it's a cheap step. If you do not get pregnant, the next step will be ovulation induction with an IUI procedure, intrauterine insemination. So we are getting into more assisted reproductive techniques, and about up to 18% of couples will have conceived. Now, the next on the most at the top, where we can see in the fertility treatment, will be known as IVF treatment or test tube baby. And at least depending on the background and the age, you can achieve up to 50% pregnancy with the IVF treatment. So, how do you choose your treatment? Go ahead, have a discussion, pros and cons. Obviously, financial factor plays an important role. Discuss with your partner, discuss with your doctors, which is the best way to head, right? So let's go into IUI, okay? Because we've got lots of things to discuss. I hope I'm not going a bit too fast, because I do like to concentrate a bit more on IVF and a bit more on your questions. Now, IUI, like I mentioned from the previous slide, is basically this step just below IVF, and it's basically where we inseminate wash sperm into uterus. When we mean by wash sperm is we basically have chosen the sperm so that you have a faster moving sperm, and we've actually placed within the uterus instead of when you have sex, it falls here into the vagina. And that may also increase the pregnancy rate, at least the success rate per cycles. We're looking at about 10 to 15% with the cost of about 500 to 3,000 ringgit. Now, why there's a big range? Because some women don't need lots of hormones to stimulate. When we do this procedure, we are aiming to have only one or two follicles, right? Growing, because normally you only have one follicle with a natural cycle. But when we do IUI treatment, we want to have maximum three, because if all are fertilized, you're going to have triplets. We are trying to minimize multiple pregnancy because there are associated risk to the mother and to the baby with multiple pregnancies. Okay, and it's usually a daycare procedure, very simple. It involves just a daycare procedure. You go home after that, normal activity, right? Simple. And you will know in 2 weeks' time whether you're pregnant or not. Possible complications are multiple pregnancy and ectopic pregnancy. But it's a good first step. For majority of people, you need to have at least one of your tubes are not blocked, and the sperm must not be too severe. Then you'll be able to do, and you're eligible for IUI. You can do a maximum of up to 6 times, but usually I would probably counsel patient maybe 2, maybe 3. At the third IUI, we will then be having another long discussion. Where are we headed, right? Where are we headed? Now, last one, IVF treatment. Now, IVF is basically test tube baby, right? In vitro fertilization, where the fertilization occurs outside the body. The eggs and the sperm are fertilized outside in the petri dish, and it's the treatment. Not only it diagnoses the underlying cause of your subfertility, it also serves as a treatment. And unfortunately, lots of people leave this to the very last, right? Leave this to the very last when the age is a bit older for both of them, and it drops the pregnancy rate. So to me, do the fertility testing, see whether you are a candidate for what sort of treatment will be best for you, and move along, right? Don't leave IVF for the very last, done IUI 7, 8 times. Have a discussion whether moving along to IVF quicker gives you that pregnancy rate faster and reduces the anxious amount of emotional stress and the amount, not to mention the financial burden, right? Even though it's expensive, it's perhaps by doing one round, you will have collected lots of embryos, and that will be your future family there, and the diagnosis is being done. Okay, so first baby, anybody? Right? Anybody knows? Our first baby was born in 1978, right? It's Louis Brown, right, in the United Kingdom. And here's the fathers of IVF, those doctors and biologists and scientists who have worked day in and day out to perfect the technique of IVF to be used in future generations. So thank you for the fathers of IVF, right? Okay, so 1978, birth of Louis Brown, and by the time that was in the United Kingdom, 2 years later, the first American IVF clinic was opened, and that was the beginning of a new era for fertility treatment and lots of hope for many, many subfertile couples. Right? Since then, we have lots of advancement in the IVF treatment. I would say it's not 100%. So people always assume that IVF would be 100%. It is not, right? It is not. So let's go through back the history. From 1950s to the 1990s, we all still learning how to freeze the sperm, egg, and embryos. With the first frozen sperm was way back in 1953. The first successful pregnancy with a frozen egg was way back in 1984. First pregnancy with a frozen embryo was 1999, and we have been successfully culturing embryos in our culture media system. So there was lots of advancement in the IVF lab to contribute to the increasing success of our IVF treatment. Okay, we'll talk about this later, a bit more detail. Now, the first ICSI, also I will be talking about it. What's the difference between IVF? What's the difference with ICSI? Okay, it was first performed in 1987 with the first born in 1992. Again, by the 1990s, where you have all this biopsy of the embryo, Pts Pgd, which I'll be talking about more in detail later in the next few slides, to determine the genetic health of the embryo prior to transferring back into the uterus by the embryo transfer procedure. Okay, so we'll talk about it later. But here she is. She's turned 40s, I think, a few years back. She's born in 1978, and she's Louis Brown. And even the sister was conceived with IVF, and it's basically due to blocked tubes in the mother. Now, more than 5 million babies are born through IVF. So it's not something new. IVF, and is basically, to summarize, it involves 5 steps of procedure. Okay, the first one is stimulation, and this involves injections of hormones. More and more, we're trying to perfect this stimulation protocol to have less injections. Obviously, it's the aim to have less side effects. Usually starts on the second day or the third day of the cycle and runs for about 8 to 12 days of injection. So that becomes the stimulation. After that, when the follicles are mature enough, it will be retrieved by the procedure known as egg pickup or OPU, and that will be taken somewhere in the middle of the cycle. And the eggs retrieved will be fertilized on the very same day of the egg pickup with the sperm, and it's been done in the lab by our scientists called the embryologists. And the embryo will be cultured in the culture system for the next 3 up to a maximum of 7 days to see whether we can have a viable embryo from the eggs retrieved and freeze it for future transfer. So now the transfer is the last step. Basically, it's basically transferring the embryos into the uterus. It could be a fresh transfer, means either 3 days or 5 days after the egg pickup procedure, or it could be done later, either maybe 1 month or 2 months or years down the egg pickup procedure. Okay, so 5 basic steps, right? And then this is also very important. I'd like to let you know about it, how the embryo is the egg which has been fertilized by the sperm. So this is day 0 is the day of egg pickup. Day 1 is the next day. So once we have it fertilized, then we'll see the fertilization. The embryologist will see there will be a structure in here, which we then will say we have 2 pronuclei, it's fertilized, right? So 2 days later, we can start seeing the embryo has divided into 2 cells to 4 cells. And here is 3 days, it has already divided into 6 to 10 cells. And here is about 5 days. So this is a day 2 embryo, 2 days after egg pickup, day 3 embryo, 3 days after the egg pickup, and 5, 6, 7 days after the egg pickup, the embryo is now known as a blastocyst, right? Blastocyst. Okay, so good. Now, I promised to tell you about IVF versus ICSI. When we talk about IVF treatment, we can actually, how do we fertilize the eggs with the sperm? There are two techniques. First is the conventional IVF, where this is the eggs, right? We have one egg and we put millions and millions of sperm in the petri dish, and the best sperm wins. The strongest, the fastest will be able to penetrate the egg and fertilize it. However, we've noticed that with future advancement in the technology, it's also another treatment which is in the lab. So when it concerns the patients, it's the same thing. You stimulate, you have the egg pickup, and then you have the transfer. This is all the techniques that's used by the scientists in the lab, IVF lab, called the embryologist, where ICSI is a more advanced technique used to ensure that fertilization occurs. So what we do, we take one best looking sperm, best morphology sperm, inject it directly, help it and assist it directly injected into the egg, right? So to ensure that fertilization is better. Now, if you can see, this is actually better for those couple who they have severity in numbers or quality of the sperm. But if you can see in the modern IVF lab, a lot of patients will have this ICSI done because it's very difficult to turn around after the egg pickup and say that you have no fertilization, even though the egg numbers are really good, right? So some have fertilization issues, and this is overcome by the ICSI. Okay, so IVF versus ICSI. Have a chat with your doctor, which is perhaps more suitable. But in this modern IVF treatment, majority of you, 90-80%, would have done an ICSI. Okay, so when we are culturing the embryos in the lab, right, we actually have a few times that we actually see for the development of the embryo to indicate whether it's a good embryo or not. So day 0 after the egg pickup, about 16 hours, you want to see whether there's a fertilization by the appearance of these two pronuclei. And you have a look again at maybe about 26 hours after that for 2 cells, and 44 hours after that, maybe 4 cells. By day 3, it's about 8 hours after that. So you're taking it in and out, right? The embryos in and out of the culture system. So what we've done is basically there's a new technology called time-lapse embryo imaging embryoscope, where you have all of the embryos within here. You do not need, and there's a camera within here, and you do not need to take out the embryos from its place, so that you minimize exposure to the air, and perhaps that will reduce the quality. And it's basically taking camera shot all the time, and you just have a look. And I think in future, with AI technology, artificial intelligence, they are trying to see whether there's a pattern and whether you'll be able to detect better embryos, which will give you that pregnancy rate that you want, because we want to choose which one becomes the best embryo, and that will be determined with the development. So you can have a look here, the next slide, at where they are in the development of their culture within the culture media. Okay, so but as far as I know, so far, embryoscope has not been proven to improve the pregnancy rate. So it's something nice to have, something extra in the lab. People love it. It's new technology. But we do have it at the moment, not yet. But I think more and more, lots of systems have been developed, especially for the AI, artificial intelligence, to see whether we can learn much more from seeing the embryo developing inside the embryoscope. Okay, so next one. Okay, I've promised to talk to you about the Pts, right? We go through again, same thing. How many is the percentage of normal embryo? Why do you want a normal embryo? Because then that gives you a normal pregnancy, or else it will have been miscarried for majority of the abnormal embryo. So if you can see, the younger you are, the number of blastocysts, because not just because the embryo looks beautiful doesn't mean it's normal. So that's why you can see people saying, look, I put in a beautiful embryo, my doctor says it's beautiful, I have still not yet gotten pregnant. So one of the reasons for that, because even though it looks good, genetically it's not normal, it's not going to implant. So if you can see, blastocyst is the stage where we can actually biopsy the embryo. Day 3, we've done it before, but unfortunately we've moved away from day 3 biopsying to day 5, because I think the pregnancy rate is much lower. So we only do day 5, or we call a blastocyst um, um, biopsy, i.e. Pts or Pgd. So if you can see the percentage of normal blastocysts, if the patient is less than 35 years old for the female partner, about half you will have a normal embryo. So there is less importance of you to perhaps do a Pts, because maybe most likely half will be normal. And Pts or Pgd actually incurs extra cost for the couple on top of the IVF treatment. They will be then, charged for extra. So we want to really know which and select the couples which will benefit from this extra procedure, additional testing. Now, if we were to see up to 40, 41, you can see the numbers drop. And by the time you hit more than 42 years old, only about 11% would be normal, right? But if you were to check egg donors, why they have such a high, they are really young, really young female donors, then you expect this, more than 50% would be normal. Okay, so PGS and PGD, this is a nice, beautiful blastocyst, right? The structure, it depends. You've got an inner cell mass, which becomes the future baby. Then you have this second line of cells, which we call the trophectoderm. And this trophectoderm will be the future placenta. It can be biopsied, right? As you can see, the process of biopsy, just take a few cells and send it off to the lab to determine chromosomally whether that embryo is normal or not, and the embryo could then be frozen back again to be taught in future to be used and transferred back if it has been shown that it is a normal embryo. So technology advancement, you have free PGD, PGS, right? It's basically the technique or the procedure to biopsy the embryo or a blastocyst to make sure that either whether it's normal, right? So you have two things, right? The PGD is pre-implantation genetic diagnosis. It's a diagnosis of a definitive genetic condition. It's to provide disease-free offspring, right? Whereas PGS is to show basically whether the chromosome is normal or not. It aims to improve the IVF outcome, i.e. pregnancy rate. Okay. So what are the indications for PGS, PGD, genetic diagnosis, where there are repeated failures of IVF? Like some patient will come and say, look, I put grade A's, grade 1 embryos, I've done twice, I've done 3 times, I'm still not pregnant. Where is the cause? How can I improve? So maybe PGS would offer an important more information and choosing, basically, especially if the couple has lots of embryo. So, and also if you have a thalassemia, you would do a PGD, basically to aim to have disease-free offspring. Recurrent miscarriage, basically, again, miscarriage perhaps due more to genetic problems or chromosome abnormalities. Again, we are choosing so that you have the best embryo which are normal genetically to have that pregnancy rate that you want. Female more than 40, well, this is plus minus. Again, why? Because we want to choose the best embryo so that you have reduction in miscarriages and a normal pregnancy. Or perhaps you've had affected inherited genetic disease. This would then, depending on genetic disease, we would then counsel the couple which investigation you should be able to do. Now, moving forward, 2008 and above, change to make the names have been changed just to make it a bit more accurate, just to make sure that you're not confused. The PGS now stands for PGTA. PGD is basically stands now for PGM, and PGD for chromosome rearrangement is PGT, SR. It's just nomenclature. Okay, so don't worry, don't be too confused about it. Right? We can always ask the doctors. Now, again, unfortunately, Pts Pgd is not foolproof. With all technologies, it takes time to improve. Now, the problem with this taking biopsy from this blastocyst, so-called, it tends to autocorrect itself. It's our nature. I think we're a living biological, um, uh, living where you change, you can adapt. And we call this embryo self-corrects. So sometimes when the biopsy at that point of time is abnormal, but when they self-correct, it becomes actually normal. So how do we know whether this is going to happen or not? And what happens if the cells turn out to be mosaic? Mosaic is basically a condition where the embryos have a mix of normal and abnormal cells. So how do we know whether we're going to accept that mosaicism, especially if there's no other normal embryos, right? If you have normal embryos, not a problem. But what do we have? The only embryos we have is a mosaic. So what do we do? Where is it normal? Do we transfer or do we reject? So these are the dilemmas, and further ongoing research and a discussion with your IVF doctors should take place, and an informed decision make with regards to tackling this issue of mosaicism, right? Now, we want to know when we stimulate IVF, right, is the correct dosage, because sometimes it's not easy. How do we determine what dosage do we use? Age, yes, plays an important role. The antral follicle count plays an important role, and also the body weight of the female partner. Obviously, if she's overweight, she will need more injections. That's something that we know, right? So Recoval is a new medication or a new hormone injections to stimulate the patients and to give individual IVF dosing based on a blood test called anti-mullerian hormone. What's anti-mullerian hormone is basically it's a blood test. Is another good accurate test on top of the antral follicle count. It costs maybe roughly about 200 to 300 ringgit. You don't need to take it fasting. You can take it at any time of your menstrual cycle and gives you a number. Right, for me, if I see according to the unit of the picomole per liter, what numbers I count for my antral follicle count, it's roughly going to be the same as the anti-mullerian hormone levels in picomole per liter. So if I get about 10 level anti-mullerian hormone, I'll roughly see about roughly 8 to 10 antral follicle counts, right? So the good thing we can try, I have it's already in the Malaysian market, Recoval. You can speak to your doctor about, and usually I'd like to reserve this for those who are Pcos, means I don't want to give too many to them. I don't want to give too little. So we're aiming roughly about maybe 10 to 15 number of eggs per egg pickup, right? So we would like to achieve that. And there are patients who are, not who we give the dose is a bit different. So hopefully by giving this is a tailored approach, you have your individualized dosing and you have the optimal number that you should be able to collect in order to give you a good number of embryos and that pregnancy rate that you want. Okay, so it's evidence-based, it's personalized dosing algorithm based on the AMH and body weight. So by giving the number that is recommended, the dosage of the Recoval, then you hopefully will be able to not give too much or too little, just nice, in order to get the perfect number of eggs that you want. Okay, so I'm out of this one. Yep, so how do I get? Okay, big technical issues. Hang on, we'll get back. Yeah, thank you, make you. Right, so another thing, right? I know that, we live in a modern era. For female, we're juggling more and more between career. I mean, we've given the opportunity compared to our predecessors. We've been given more opportunity for education. We've been given more, opportunity to go up that career ladder. But we still need to deliver babies. Unfortunately, we can't get the husbands to deliver. If we can, fantastic, we can share all those, right? And we take turns giving birth to babies, right? So unfortunately, we have been given the task biologically to give birth to babies and have our family. So then, I think things are given for those who can handle it. So I think women are able to juggle, but we need to balance between your career and building a family. Of course, depending, I can't say for everybody. Some would love career, some would just go like I don't want to be a mom. But for majority, they would like to have both. Why not? Right? Everybody wants to have both. But sometimes because of the biological age, we need to choose and not delay treatment longer so that we don't miss the boat of becoming mothers, right? So some people have opted for egg freezing. Now, freezing, that's another new technology that we've developed in the lab, which has revolutionized IVF treatment, because now we can freeze. We can freeze the sperm, we can freeze the egg, right? We just can't freeze our age, which should be perfect, right? Freeze our age, forever young, right? We'd love that, forever young, fantastic, no need to deal with all this old age and things, but we can freeze the eggs. And the method that we freeze it is rapid freezing. So the last time we used slow freezing, it causes a bit of issue in terms of the quality of the egg, especially when you freeze it and when you thaw it. But by using this technology called the vitrification, where there's rapid freezing of this tissue or these cells, it does not causes lots of damage when you are freezing and when you're thawing it. So it's fantastic. You can freeze the egg, sperm, and embryo, right? So it's an option, but my caution is for you to freeze the eggs, especially for women when you're younger, actually 29, late 20s, early 30s, not when you are like 40, early 40s. You will have poor eggs, poor sperm, poor eggs and numbers. It's not going to be a good eggs to freeze. Okay, so let's say you have the opportunity. It is expensive, right? And you have that options of egg freezing, and this technology has also been used for those unfortunately been diagnosed with cancer, right? Freeze the sperm, freeze the egg, especially if they're at a younger age. So this has been given the technology, and on top of that, we can freeze the tissues of the ovary. Okay, so sperm, eggs, and also the tissue of the ovaries and embryos. So that's all the new technology. Yep, it seems that we can beat the biological clock. Unfortunately, we still are struggling. We still do advise patients to, at best, if possible, go for early investigation, early treatment, so that you will have still a very high success rate. Obviously, we're always trying to move ahead, have a new technology, have advances not only in the lab, right, and how we stimulate patients in order, and also most important, we want to reduce the cost. I think cost is another important thing that you need to be able to be well versed, see what options. Sometimes you go, wow, cheap. But if you do not understand the process, you probably say, why is this center giving cheap and this a bit more expensive? There are a few factors that you need to take into consideration and see what's actually in the package. And not all packages are suitable for everybody, right? The mini IVF or the full blood stimulation of the package, you need to be able to see properly, is that package suitable for you and what's inclusive inside it. Okay, so I hope that in future, right, as we do know, fertility has becoming an issue for developed and also developing countries. I think in developing countries more to do with barrier, access barrier to getting a good fertility treatment, and also cost. But in developed countries, I think we're dealing more with perhaps age, and egg quality, egg sperm quality, even though they are probably perhaps more financially better compared to the developing countries. Okay, I'd like to talk about success rate. Okay, success rate. it's important to be able to digest. Okay, you can't just compare. Okay, this is the success rate for all clinics. There are a few important things that you need to be aware, because some clinics may decide, since the success rate is so important, and that they will just turn down couples which are deemed as poor prognosis rate. So if you can see, their success rate is better. Why? Because they are doing good prognosis patients. So these are some of the key factors that you should be aware of when you are assessing success rate. Unfortunately, in Malaysia, we do not have that statistics as for overseas, where they have in UK the HFEA, and also in America, where they give the success rate of the IVF clinics or fertility center. We do not have that in Malaysia. Okay, so but we hope to at least give you the success rate per frozen embryo transfer, okay? Because we do lots of frozen embryo transfers, um, uh, which, we hope that that is actually better in terms of pregnancy rate. But I think it depends on the patient. If you feel that you want to have a fresh embryo transfer, go ahead, have the discussion with your fertility doctor. But for here, we are talking about a frozen embryo transfer 2018 success rate. Again, do not be surprised with the it depends on the age group. So if we're looking at less than 30, from this side up to going up to this side, right, where it's more than 44, clinical and ongoing. Why clinical? Clinical basically means we saw a fetal heart, right? That will be done at about 6 weeks of scan. So means it's roughly about 2 weeks after the, not 2 weeks, a month after the embryo transfer, because roughly about 2 weeks, you know your blood test, and about a month later, you can actually listen to the fetal heart. Right, so if you can see clinical, it's about 57, but you will have some miscarriages, so that becomes about 50%, less than 30. And if you were to see about 30 to 34, it's less than 50, so slightly below 46.8. And for 35 to 39, this is about 45%. So I would say our prognosis from 30 to 39 years old women, it's usually quite a good pregnancy rate. Of course, it depends on the background. If they has less number of eggs, very poor quality, then that affects the success rate. So this is an overall, if you can look at the statistics, right? So if you look after 40 years old, then it really drops. It starts dropping. It drops from 53 to 33. That's a whopping 20% of drop. And the ongoing, there's another than miscarriage rate. So it's at least half of it, right? When you hit, when it's 40 to 43, and if you're going to 44, more than 44, you're looking at ongoing rates of 12%. And if you can see overall statistics worldwide, 45 years old, even though with IVF, ICSI pregnancy rate, you're looking at less than 1% take-home baby rate. Okay, so do not be deterred if we sound pessimistic, if you're coming at 45 and above, because yes, statistically, the odds are stacked against you. And if you're looking that you're more than 40 years old, be mentally prepared that you may be required to do multiple cycles of egg pickups just to get that normal blastocyst and just to get that normal pregnancy ongoing. Okay, so something that you will be counseled, you need to be prepared, because sometimes patients aren't prepared. We usually would have counseled more than 40, definitely pregnancy rate is this, but I think sometimes it's maybe not concentrated, because it is quite devastating, quite disheartening to hear poor pregnancy rates. So patient, despite us telling them, they may fail to take it in abort. We have to keep telling them again and again, but we usually would like to prepare patients, especially if you're more than 40. But we still have a pregnancy rate. You can see you're looking at 40 to 43, still a good pregnancy, ongoing 25%, and not too bad, okay? So we always, the main important for the bootcamp, we'd like to prepare patients. I don't really like if the patient comes in day 2. I've never seen the patients. She go, right, I'm here, day 2, day 3. let's start going. I'd like to go for IVF. Um, unless they're prepared, unless they're prepared, then yeah, let's go. By all means, let's go. Minimum 1 month, best 2 to 3 months before starting your IVF cycle. Have a look. We're monitoring, and some patients, especially even the older ones, do get pregnant spontaneously while waiting because we are preparing. We know the right time, and it does happen. Okay, so COVID, very important. Last 2 years, it's still here, but I think people are sick and tired of it. It's now become an endemic. We're just gonna have to live with it. We actually have been doing fertility treatments. We've been fortunate enough, but doing with the regular SOP, we have been, doing ongoing clinics since May. So lots of pregnancy, lots of deliveries. We of course we be tailoring according it. We do ask the couples to do a COVID RTK about at least 1 week, a few days before the egg pickup. For the transfers, we do not ask them. So we can see this is the consultants and the anesthetists, for our fertility clinic, okay, our fertility. Right, we are moving to vaccination. I do have covered in previous lectures with regard to COVID. Yes, to me, please go do your COVID. I think it's probably, if you weigh the benefit and the risk, just do it. Even though for fertility couples, it has not been shown to affect the egg quality and sperm quality, even though we've noticed that sometimes after the vaccination the period gets a bit longer, not in all, in some, but it has not been shown to affect the egg quality and the sperm quality, right? So go ahead, do your COVID vaccination. Please do that so that you're safe. We don't want you to be pregnant and you're actually unprotected and you start having COVID infection while you are pregnant. It's even worse prognosis, right? So please, 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 please go and have your COVID vaccination. In some cases, if you were to see in KKM, they've just taken, a bit much more cautious approach. They'll ask patients to wait for 3 months after the COVID vaccination. I will probably wait a few, maximum 1 week, maybe a month. But some the recommendation even for overseas. They probably take it during the same time. But I'm just worried some patients might have fever after the jabs. I'd like to not have the egg pickups during that time. So I usually have a bit of a gap, right? Okay, we do ask patients to do the rapid test. It's just an antigen. Some places require PCR. Ours is just antigen. Okay, before the egg pickup. If you can see, we've already using SOP as much as possible. We'd like to protect our patients. We'd like to protect our staffs, so we can always still provide ongoing services for you and not be waiting, because some patients have been waiting because some of the government centers, yes, I understand the priority would be for COVID, not surprising. So, but we are happy from the public sector. We are not involved in that to be able to provide an also important service to the public, which is fertility. Right. So I would also like at this juncture to advise patient. I mean, if you please use the correct SOP, right? We are living in an endemic, but if you do have any fever, if you have been exposed, please go and check your swab test instead of moving around and further exposing other people, right? So on and off, we do have COVID tests, but fortunately, we are able to control my lovely room here with a glass in between the patients, right? With a small hole. I feel like I'm in a goldsmith shop sometimes, sitting across with a small hole in between. It's just to provide extra protection. Okay. So we are almost close to the end of the session. Just a few more slides. Your fertility journey. Nobody knows what's happening, what will happen, how fast is it, how long is it, will it ever end? Nobody knows, to be honest. Everybody knows it's going to be a roller coaster. You're going to have to be prepared. So the boot camp, hopefully this session have given information. I'd like to also take the opportunity to tell you to prepare yourself emotionally, have the knowledge and prepare. correct? Because we do not know what's going to happen. Don't scare yourself because lots of, hear the bad things. There's lots of things which happen well, right? If you have a little few bumps here and there, it's part of the journey, right? We'd like you to move along your life journey with your children and your family ahead. So I hope that majority of you would move fast, do the investigation, if needs be, move on your fertility journey soon, right? And have a plan B in order to to make sure that you are not delaying far too long. Okay, that's what we don't want because biological clock keeps ticking. Time waits for nobody. I don't want time. You find that you don't have the time and you basically miss the boat. It's very sad because we do have patients coming in, and I feel that I'm walking them through something. It's going to be moving along to most likely an unsuccessful treatment because of delay. So move quickly, and so that we can give you that success rate that you need. Because we all love to, ask you to graduate from the clinic. Graduation, have your baby, and have your baby in your tummy, and and have your second and third baby soon after that, right? So, yep, we've got lots of battles. COVID have been, something unexpected in this new century where we're expecting 2020, but we're just 2020 down 2 years, and now we're 2022 soon. So it's been quite a tough 2 years for most people, right? So we're always going to be grateful for whatever we have, and we are going to still move along, because those who are strongest soldiers, you are also a soldier in your own fertility journey. You're the strongest soldier. You have your battles to fight, and sometimes it feels hard, but remember, the hardest battles are given to the strongest soldier. So keep calm and soldier on, right? So have that courage, have that determination to take what it takes to go all the way. And hopefully, inshallah, majority we can have good news for majority or all of you that has come and choose us as part of your team to help you build that family that you dream of all this while. All right. Okay, that's my babies. I've got my fertility journey, and I'm very happy to be and proud to be a mother pair of twins. I do not choose to have twins, but you will decide between one or two. Whether you should put one or two, that's another discussion to be discussed. Obviously, we always like to have one put in, but in certain circumstances, we will decide to put maximum 2 embryos back, and that will possibly sometimes lead to twins. All right. Okay, make you back to you.
All right, thank you, Dr. Natasha. When we talk about A to Z Fertility Bootcamp, it definitely is from A to Z. Yeah, it's very comprehensive. And thank you, Dr. Natasha. That was a really, really nice presentation that actually covered everything about fertility, as well as we covered COVID as well. We have a lot of questions that actually bounced to us during the whole time, and I would like to address some of it that were actually sent to us privately first, and we will address those that are current, okay? So first things first, this is definitely one of the most popular questions, Dr. Natasha. Supplements, diet, nutrition, and what a couple should eat or not eat while on the journey of fertility.
Okay, let's start with diet. Balanced healthy diet is common sense. Like, you will know lots of fruits, lots of vegetable, berries, fish, Mediterranean diet, olive oil, all those are really good, right? You can just scroll through. There are no magic diets for you to take, right? Don't tell me, give me the top 3. Doesn't exist. Okay, doesn't exist. It would not happen. You're gonna have to fill up, go through the list, just put it inside your diet, right? Lots of fruits, lots of vegetable I showed you, and then fill it up, fill your fridge and take out all those, not meant to be there. Of course, you can have a bit of chocolate, right, here and there, a bit of, but don't keep it in your, going to keep a big stock. Just, have it once in a while. It's a treat, right? Majority of the time, eat healthily, and all these healthy foods are actually yummy. You can eat healthily and still, enjoy that food. Of course, junk food, KFC, Pizza Hut. No, 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 no. Right? Extremely. It's junk food. Don't eat that, especially when you're trying. Okay, be healthy. Smoking, no. Okay, husbands, wives, no. Husbands, yes, no. You can't. You can't have it. You're going to have children. It's going to destroy your sperm. And it's no point me giving you that 200, 300, 400 ringgit worth of supplement when you're smoking. It just, it's not going to happen, right? So you're going to be probably trying so hard, spending so much money when you need to just first do simple things. Stop smoking, have a healthy diet, exercise regularly, have regular sex. And quite a few times we have patients coming and they're pregnant within 1 or 2 cycles, all right? So it's very easy. Supplement, yes, sometimes we need supplements because we are not taking adequate. My usual advice is folic acid, 400 to 800 micrograms. Then we have multivitamins, fish oil, coenzyme Q10, right? That one you can go to the pharmacy, take a supplement, ask them, so look, I've got this list. Tell me what's a good prenatal supplement. Very easy. Okay?
Okay. So the next question that we would like to address is about PCOS. Yeah.
Okay.
And what would women with PCOS would have to do to prepare for pregnancy?
Okay, so PCOS is basically a polycystic ovarian syndrome. It's a hormonal disorders and which lead to an ovulation, means the patient does not ovulate regularly due to the follicles do not mature. Why does the follicle does not mature? Hormone imbalance, especially a hormone called insulin, which controls the sugar level. And PCOS for the majority of patients can be rectifiable by again having good diet, reducing your excessive weight, even though as little as 5%, because majority of the PCOS patients are overweight or obese. Okay, I know it's probably hard to reduce the weight, but with determination you will get there. 5%. Don't concentrate on that 20 kilos you have to lose. Concentrate on the 3 kilos or 2 kilos that you have to lose monthly. Baby steps and you'll get there. Okay, so it's actually a lifestyle. Change your diet, right, a little bit, and exercise at least 3 times a week to reduce the weight, or maybe 5 times, depending on how overweight you are. So it's actually good to have, advice, see the dietitian, or actually have friends who wants to lose weight, because it makes it a bit fun. And sometimes you do need pom-pom girls, supportive group just at your side to keep you motivate. Sometimes you have that trainer. It's just not, people sometimes it's not common. We slack off, right? We slack off, and sometimes we just lazy. We just don't want to do it. It's so simple. But when actually get going, somebody push you, encourage you, motivates you, you will still be maintaining, because you need to have that stamina, that momentum to keep you going, right? Even with fertility journey, to lose that weight. You will get there. For some patients, they may have more bit metabolic disorders. I would refer them to the endocrinologist, because they're probably more than 100 kilos weight. It's going to be quite tough for them to be struggling alone. So we will have some medical input to quickly see them lose that weight, and that will give them the encouragement and the support to further lose weight. And by losing weight, some patients spontaneously gets pregnant. It's not uncommon, right? For years we have 10 years, and I'll do the egg pickup. And patients with PCOS, is a challenge to stimulate them because they have lots of follicles. But when we give too little stimulation, the eggs doesn't grow. But when you give too much, then it becomes excessive. You have 20, 30 eggs. You don't need that many, and becomes hazardous, dangerous for that patient, because you will have a condition called ovarian hyperstimulation and can be fatal. So that's one of the challenges for modern stimulation. So I'm looking forward to Recoville. Less is probably more. To me, safety comes first. So maybe you go like, wow, only 10, only 8. Yeah, but I can't risk your life for it. Okay, I can't risk your life for it. So we're going to have to just find a way of stimulating just enough, 10 to 15, without tipping you over to 25, 30 eggs. Too much. It's just way too much.
Okay, so since the women with PCOS may have
A lot of
more issues now,
yeah.
what is your advice whether to transfer one or two embryos of the
Right, for everybody, we will always transfer one.
Yes.
One is the best. For IVF modern, it's embarrassing to say you have triplets. It's actually an embarrassment, right?
Yeah.
For so I wouldn't be like twins, because people love twins. I'm okay with twins, but to say, oh, I have triplets and I'm proud of it, is I'll be embarrassed. Not as an IVF, the modern IVF especially will be too embarrassed, because I've actually had to put so much in order to get that pregnancy. If I'm really good, I only need one good embryo, give a healthy full-term baby to the parents. Fantastic, one at a time. Okay, but know your background. Less than 30, you've got lots of embryo, good embryos, one. Okay, but if you're probably more than 35, you've probably had failed cycles outside, I do understand, maybe two, but do understand that may be risk of multiple pregnancies. Okay, so you need a few things that we need to know. Twins, multiple can be twins, can be triplets. The last time it can be 6 or 7, unheard of, because if you're putting 3, sometimes it splits, right? You're going to have quadruplets. So even though we put 1, blastocyst, you can have 1 to 3% of patients splitting, right? So you have put 1 embryo, you've got 2. But what about if you put 2? So far we've had 3 sometimes. Luckily, or else we could have 4. It's really scary, right? Because how are you going to carry 4 babies in your tummy? I think we've seen that in the Caucasians, hardly in Asians. I think we're much smaller built. 3 would be very tough to carry, and lots of complications. Even twins, lots of complications, right?
Okay, so we have a question here. Okay, fibroids.
Yeah.
Also very common question.
Okay, fibroid basically is because our uterus consists of a muscle layer, and sometimes overgrowth of the fibroid, overgrowth of that muscle layer is what we call fibroid. Now, fibroid, whether or not it affects fertility, depends on the size of the fibroid. Let's say if it's more than 5 centimeter, it's quite big. But again, it depends on the position of the fibroid. Where is it located? If it's just outside the lining or in the middle or the muscle of the fibroid, it does not cause any symptom. You don't need to cut it out. If it's inside within the inner layer of the uterus, then yes, it will affect the fertility. And even though it's small, we would probably say take it out, right? Yeah. So basically, you will have to be assessed and see.
Okay, for women with a longer menstrual cycle,
Yeah.
like sometimes 30 to 34 days now, how do they know and how do they track their ovulation?
Okay, right. The ovulation tracker, 50% is inaccurate, right? So probably better is have regular sex 2 to 3 times a week, or you can use the ovulation test, right? Testing for the ovulation, but you don't need to be obsessive about it. You can try it. Don't be too hazily obsessive about it, and it creates a bit more stress. So now, if you're having about 30 to 34 day cycle, your ovulation will be roughly about 16 to 20 days of the period. So if your first day of period is on the 1st of November, you're probably ovulating either 16 to 17 to 18 or 19 or 20 of that cycle. So we will say alternate days, right? Unless your husband say, all right, we're going to go every day. You don't need to do that. If his sperm is good, alternate days is good enough, right? Okay, and 30 to 34 days is still regular.
Okay. Now, we are talking about COVID vaccine. Like I think half a year ago, we were just talking about the first dose, second dose. And now we're talking about booster now, Dr. Natasha.
Even we are having...
I know. So things are continuously developing now, you see. So do you have any thoughts on this?
Well, at the moment, we're having for frontliners, I don't think it's... we're constantly being exposed more and more take-ups with the frontliners. Yes, and we do see some side effects. Rarely we see severe side effects, which causes inflammation of the heart. Majority are okay, but we can see with vaccine, we've managed to reduce and change pandemic into endemic I think something that is quite difficult to avoid at the moment. We'll know more and more information like we did the last time. Yay, nay, stay at home for 1 month, don't know what to do, open, close clinic, what's happening, you know. And we've moved to say, yep, go take the vaccine. No questions about it. No vaccine, we're not pushing. And then we're like waiting for the vaccine. Yes, no, initially people were scared, and suddenly we're like, now where's my vaccine? You know, we've gone to one stage to another stage. So now again, it's the same thing. Booster, yes, no. Difficult to say, but I'm taking my 3rd booster tomorrow.
Oh, good for you,
So-
Dr. Natasha. Good for you.
So hopefully, you know, so hopefully not much side effects, but you know, I'm prepared about what to do. Something that is I'm not sure whether it will be an option, but the first 2 doses are not an option, obviously, seeing the way government is heading. If you're not having any option, there you go. You're not going to any restaurants, so you're just gonna have to do your first dose anyway. 3rd booster, I think they're probably gonna make it optional. We'll see. I mean, if the number doesn't come down, I think they're going to make it more or less again compulsory, right? If the numbers keeps going on, you know, you just can't. It's 2 years already. I think it's going to be too much, I think, for all of us.
Okay, so let's move on to from the A to Z fertility type of fertility treatments. Now we've come to I, which is IUI. So this couple has actually failed IUI twice. Now she's actually very anxious now. Whether if she's going to fail the 3rd IUI, will she have any good chances in IVF?
Okay, this will depend on your background. How old are you? What's the female age? How long have you been trying? Is there financial issues in terms of, and what's the cost, underlying cost, right? If to me it becomes A and B, not everybody will choose the same, right? But bear in mind, if you're a bit older, right, 35, you've been trying longer, more than older, 35, make you laughing. We always say we'll take it as 35. I know 40 is the new 35, but for biological it's still 35 at the moment. But for the new age, 40 maybe, yeah, but not for reproductive, unfortunately not yet. It's still 35. So if you're more than 35, trying for more than 5 years, have much more severe cause in terms of sperm issues, or one of your tubes are blocked and you've tried twice, and IVF is not a much financial burden for you, go for IVF, right?
I was just actually also laughing at this Vector Chua saying, I love treats. Just and I do too. Yeah. I think they are cute as a pair, you see.
Yeah.
In Chinese custom, it's called the Phoenix and the Dragon. You know, you really have good luck with the Phoenix and the Dragon, but until they wreck your home, there's no more, they are truly a dragon and a phoenix then. Okay. So next, I think we would like to actually address this a viewer question. Is about it's very sad. I'm sorry to hear about that, but we just would like maybe just go through this question over here. I think you can, Dr. Natasha is over there. So what should she do, and what would you advise her to do?
Okay, I'm really sorry that you have this. Placenta abruption actually is due to a few things. One of it is high blood pressure, right? High blood pressure. So I'm not sure about your background. Unfortunately, you did not have a live born. So was on Vsand. Maybe you had a bit of endometriosis as well, but very little. Whenever you're ready. Sometimes with Vsand, it takes a few months, but usually Vsand after 2 or 3 months, it should be settling down. It's time to basically prepare for the pregnancy, right? Have a discussion why you actually have placenta abruption. Sometimes you don't know. One of the major cause is high blood pressure. So if you do have high blood pressure, we need to control it. But if you do not have it, when you are pregnant, you may want to consider taking baby aspirin as soon as you know that you're pregnant. Monitor your blood pressure closely, right? And a fertility doctor when you're ready. I think after you've stopped, maybe 2 or 3 months after that. Sometimes yes, the first few times your period might be less, so we'll be monitoring that. But I think as the times goes on, after the 2nd and 3rd month, it will be much better. Okay, so you stopped it about a month ago. If you are ready to get pregnant, or maybe you just want to have a checkup, you can go and see the doctor, have a check, right? What can I do before? Because I don't want you to get pregnant immediately. There will be probably some things that we want to prepare first before you embark on the pregnancy. And so that one before pregnancy, as with IVF treatment, I usually like to see patients about 2 to 3 months before actually getting them pregnant. So 1 month ago, go ahead, go see a doctor, have a chat to the doctor who taken care of you the previous pregnancy, see what can you do to prevent perhaps future placenta abruption. Have a look at your uterus lining. Are there any issues? Have a look at the ovulation. Okay, and when you're ready, start taking your folic acid, and when you're pregnant, maybe baby aspirin as well, and close monitoring of the blood pressure and the baby's growth. All right, my best, my prayers for you for your future pregnancy.
Hang in there. I think you'll get there. Just take care.
Yeah.
Be emotionally ready first. Yeah.
Yeah.
All right. So the next question is: this lady has endometriosis, hyperplasia stage 4. She has been on Mirena for almost 6 months now, and I think most likely is when should she go for IVF, and what is the success rate for her case? Yeah.
Yep. For endometriosis again is something endometriosis hyperplasia. Okay, I think she has some hyperplasia, stage 4. So we need to be careful in terms of it becoming endometrial cancer, right? So I'm just confused, but I think it's basically endometriosis stage 4 because you can have endometrial CA, right? But I think you are talking about endometriosis stage 4, and you're on Mirena 6 months. Okay. Now the issue now, if you have stage 4 endometriosis, it's best to do IVF. You give a better pregnancy rate because sometimes the tubes and the egg quality and the number becomes less. All right. For success rate, we're always fighting the eggs. Don't forget, don't be obsessed about the success rate. Go for it. Okay. If I were to tell you, I've had 3 failed IVF, and there was this quiz which I done. Luckily, after I was looking at it, I said, should I do it? And I had already successful, already I had delivered. My success rate was about 14%. It's even worse than IUI. And I'll be like, if I have done it before, would I have been discouraged to do my IVF? And that probably would I've never done IVF. I would have my children. I'll probably be totally, so discouraged. So to me, yep, success rate is success rate, but where you are you going to be that 80-90% is not going to get pregnant because you didn't even bother trying? Or are you going to be that small, uh, group which do get pregnant, even though it's so-called poor? Why not? Just give your doctor have the experience with endometriosis, because we do have lots of patients with endometriosis, stage 3 and stage 4, which do get pregnant, right? Alhamdulillah. Never give up trying, and make sure you don't give up trying until it's good, because some people comes late in the age and we don't know what to do with them, right? Because we do try so hard for them. So if you can see me aggressively pushing, not because for any reasons, it's just for me wanting you to have the best successful rate. Okay, and that comes with age. The more you delay, it goes down. All right.
Okay, so let's talk about ERA.
Okay.
Not ERA Fazira. Huh?
So ERA is basically a treatment when we have failed IVF cycles, right? We don't know whether is it the embryo is an issue or is it the implantation timing, right? So ERA is basically a test where we take the lining of the tissue, a biopsy. It's very simple. It's almost like having a pap smear, but it costs much more expensive with lots of zero at the back. So ERA costs between 5,000 to 8,000. It simply means a test to determine the right implantation timing to put the baby for IVF treatment. Okay, so 5,000 to 8,000 means it needs to be the cycle before you do your embryo transfer. You need to take a sample, and the regimen that's been used is usually hormone. You take over the cycle, and depending on the results that's been sent to Japan, usually it takes about 3 weeks. We will alter the treatment. If they say it's receptive, according to doctor, fantastic. They say it has increased in 20 to 25%. I'm not sure. I think they've got lots of studies. It is an option with all this additional treatment, additional. I don't push patients for it because I don't have enough evidence base to push it. To be honest, right? To be honest, so ERA is something that I may do in the younger patients, which I'm not sure why they have not implanted. Okay, it's something that I would probably opt for, especially if the patient wants. Yep, no problem, we can do it. And hopefully we get a pregnancy rate, but at the end of the day we don't know, because ideally if you want to do everything, you do PGS, you do ERA, you do intralipid, you do every single thing. Which one is which? Because it's a cost. Which maybe you don't even need to do the ERA, to be honest. But who's going to do IVF on top of that, do PGS? That's 3,000 per embryo. Sometimes that's really expensive. Ideally, obviously, everything's done, but some patients don't even do a PGS, but they did an ERA cycle and it had failed the previous one. You never know. It could be due to abnormal embryo. But if it was at the PGS embryo, it still failed. Yeah, go ahead, do your ERA.
Okay.
Right? Might be a wrong timing.
All right. So now during an IVF
Mm.
stimulation process, can the woman
Yeah,
go
go
for exercise? Go for swimming.
Yep, I think gentle exercise. So what I usually do, maybe during the injections, you probably start on the second day. You've got the scanning at the 6th day, 9th day of your period. By the time you're 11, 12, 13, 14, follicles are starting to grow. I prefer gentler exercise. Swimming's gentle. Walking is all right. Yoga is really good because lots of breathing exercise and just stretching. You need that to keep yourself sane and also fit and mentally prepared for whatever it is, right?
Okay. So I have a question for you, doctor. We have received many types of this kind of questions. Now, a couple has already been pregnant, okay, with the first time of embryo transfer, and they have embryos frozen, and the embryos were not as nice as the first round, but it's still transferable, and they have only one left. One. All right. So looking at the quality of the embryo, which is not as nice, and they only have the low number, which is one. So what is your advice?
But you had a pregnancy rate before.
Before, yes.
Well, if there's only one and they're paying the freezing rate, I'll say give it a chance. Why not? But always have a plan B. Plan B, that if that doesn't work, go for another egg pickup, especially when you're young. Right? So in terms of what do you want to do? PGS or what they're hoping? Even the most ugliest embryo, if I'm freezing it here, there's always a chance. We won't keep those who are not viable, right? So for us, we are very strict in care of fertility, in terms of freezing. The fact they actually had frozen it means there's always a chance of the baby growing. We've had, not nice, go like, that's the only embryo, transfer it, pregnant. What to do, right? It's you can never tell. And it's beautiful embryo, transfer it, young patient, not pregnant, and go, oh dear, how? So I'd like to give all embryos a chance, because morphologically sometimes they don't look nice, but they're actually the most beautiful baby that you can have. So long as that it's not abnormal, it's just morphological, it's not as nice, it's not perfect. Yeah, why not? If that's the only embryo, why throw it away?
Okay, so this question is about recurrent implantation failure. Now,
easy.
Does immunology play any part in it?
They probably say it's like, if you were to see the conservative one, they say, look, they don't believe in it. Honestly, they don't believe it. Don't bother even testing it. It's very difficult for us. We actually don't do the test for it, but we provide intralipid, sort of to cover all these natural killer cells. It's 500 ringgit. To be honest, I don't force onto patients. It's an adjunct treatment with no evidence base for me to force you. So it's an optional thing. If you want to do it, have it, but I won't force it. It may or may not help, right? Some people say it's rubbish. Some people have some anecdotal basis that, after that, suddenly got pregnant, everything's the same except for that. I don't know, right? Honestly, not enough studies ongoing. It's an option. It's something to pursue. I know this will be for those who actually had failed so many times, and we're really trying to find how to get that pregnancy, right? Obviously, they probably have done PGS, they probably have done ERA, and they're looking at all these tests. For us, it's intralipid. Majority of people, by the time they hit PGS and ERA, they for sure are going to go for intralipid. already, right? It's an option, no hard evidence, unfortunately. And if you were to ask, quite a few, they don't believe in it, right?
Okay, I think we can answer two more questions.
Yeah.
Two more questions. Yeah. Okay. So, this is something also very general. I think a lot of people would like to know. How do I decide? You have your eyes. So, when should they stop trying naturally?
It's different people will choose differently. That's the whole idea of you consulting the doctor, even though with the two same same situation, two different couples will choose differently, right? Age, how long you've been trying, what's your problem, maybe from the investigation, and cost, basically, right? Some people will go like, sperm, you should do IVF, but they'll be like, no, it's too expensive for me. So then you go, okay, why not? Maybe IUI or something. Then they sometimes do get pregnant, even against against all odds. But to me, if they were to choose, I wouldn't pursue. Like if I were to say, look, the sperm count's really low, I'll probably say, look, maybe one IUI, but not persistently doing IUI. I prefer the couple to keep the money to do a better success rate IVF. But if they say, look, I'm not going to ever go there, okay, I'm going to still see and maybe do IUI treatment and take it from there. Okay, when should I stop trying naturally? It's again your decision, but I would say again biological clock, and do not wait too long. Right? So that's your decision, but sometimes we do have a bit of guide from our side, and we take that guide: age, time to conceive, cost factor, emotionally, are you ready? Go ahead, go do it. Right? If you tick a few boxes, then is it suitable for you to do IUI? What's your potential of having success from IUI? All right, if it's on the lower side because of your age, one tubes are blocked, sperm is not so good, cost is not an issue, go for IVF. Why not? Right? Have a better success rate.
All right, so we're gonna address the last question here. What sort of fertility test? So we're going back to be suggested if a yearly medical checkup. I think this is a very good question, doctor. So you go for your medical checkup yearly. You've done
Different.
everything, So what other tests to look at fertility?
I think medical checkup is actually quite different from from the fertility. Some of the tests, yes, blood tests, yes. For us, it depends. Always missing is hepatitis C, HIV. That one's always been missed. And then we do scans. They do ultrasounds on the tummy. We do vagina scans. Perhaps, yeah, go ahead. So if you've done that, bring the medical checkup to us. Majority of the time, it's not complete, right? It's like it's not going to be complete. We're doing totally some specific things, right? But I always check. I don't throw it away. I'll just say, okay, what you've done. Okay, let's have a look. Okay, this is the things that it's not still be done from our point of view. We will do it.
Yeah. So the next time you would like to come and see us, don't worry. Just bring back all your medical reports, your previous blood test reports. Even if you have done a semen analysis before.
Yeah, bring it. We'd like to see it.
Yeah, and let the doctor decide whether you need to repeat it or not. If you're lucky, you don't need to repeat it. Most of the time, you don't need to. But at KL Fertility Center, we do have some policies, things like sperm test and things we need to look at because different labs, different embryologists look at different things, different doctors look at different things. So I think we are at the end of our 60 minutes. I think we've gone over 60 minutes, which is very good. And we would like to share one of our doctor, I think this is Dr. Natasha's fans here. Dr. Tasha, dear mommy and daddy to be, please consider IVF as one of the alternatives to embrace parenthood experience. I did once and successful and blessed with
Alhamdulillah.
And this is definitely something that is very good news to us, and this is what we look forward to. Not here to sell, but not to say that consider IVF or not. Before you do anything like that, see a fertility specialist to decide. Okay, so thank you, Dr. Natasha, for a lovely afternoon.
Thank you,
I would like to thank our dear Miss Suraya at the background.
Also, thank you, Suru.
She has been helping us with a lot of things. So stay tuned again. We have 60 minutes fertility show again next year. Next month, not next year.
Soon, 2 months more.
It's true. So Dr. Paul Tay, one of our fertility specialists as well, will also be talking to everyone about some of the things that we would like to touch on, which is called the 5 C's on getting pregnant. So what are these 5 C's? Stay tuned, go to our Facebook page, register for our webinar next month on the 27th of November. And we actually have a new guest next month. So I'm not going to tell you, register, and we shall see you next month. Yeah? So thank you again, Dr. Natasha.
Thank you.
Raya. Thank you, everyone, and have a blessed weekend. Bye-bye.
Bye.